first line is imatinib, nilotinib, dasatinib, and the second lines are and then there are second lines imatinib, nilotinib, dasatinib, bosutinib, and ponatinib. And outcome is in 90% people achieve complete cytogenic response faster with nilotinib and dasatinib, and median survival comparable to the normal population. Side effects are that these drugs will cause nausea, increased QT interval, and fluid retention. This is important for MRCP. And yes, hydroxycarbamide is for palliative. This is also mentioned here, and interferon is safe in pregnancy. We are going to read that. Okay, in chronic phase, there are now 5 available tyrosine kinase receptor inhibitors. Tyrosine kinase inhibitors for the treatment of CML. These specifically inhibit BCR-ABL tyrosine kinase activity. Imatinib, nilotinib, dasatinib are recommended at first-line therapy in the chronic phase CML. They usually normalize the blood cell count within a month, and within a month and within 6 months produce complete cytogenic response, disappearance of Philadelphia chromosome. So what happens is that if the Philadelphia chromosome disappears, we say this is good. Okay. And in some 90% patients, the sample of the bone marrow is taken at 6 months to confirm complete cytogenic response, and the patients are subsequently monitored by 3-monthly real-time quantitative PCR for BCR, ABL, mRNA, the gene product, transcripts in the blood. The aim is to reduce BCR, ABL transcription levels by 3 to 5 logs from the baseline, and this is called major molecular response, MR3 to MR5. MR3 to 5, 3 logs to 5 logs हमने इससे नीचे गिराना होता है. A proportion of the patients achieve a complete molecular response where the transcripts are not detectable by PCR. It may be possible for the patients with a complete or major molecular response. अगर तो complete response हो गया तो you can stop TKI therapy, and this is being investigated in the clinical trials. For those failing to respond or who lose the response and progress on first-line therapy, options include switching to a different TKI. Some patients develop detectable mutations in BCR-ABL gene, which renders them resistant to one or more TKIs. The T315I or L mutation has been particularly problematic. So this mutation is problematic as this provides wide-ranging resistance. The third generation TKI, pontanib, is effective. However, allogeneic hematopoietic stem cell transplant is now reserved for the patients who fail TKI therapy. Hydroxycarbamide and interferons were previously used for the control of disease. Hydroxycarbamide is still used in palliative situations, and interferon is used in the woman during pregnancy. Okay, now for the treatment of accelerated phase in blast crisis. Management is more difficult for the patients in accelerated phase. The TKI therapy is indicated most commonly with nilotinib and dasatinib. Nilotinib and dasatinib. यहाँ पे था हमारे पास nilotinib and dasatinib. Okay. When the blast transformation occurs, the type of blast cells should be determined. Response to appropriate acute leukemia treatment is better if the disease is lymphoblastic than if myeloblastic. So, response to treatment will be better if the patient has lymphoblastic leukemia. Second or third generation TKIs such as dasatinib are used in combination with chemotherapy and try to achieve remission. In younger and fitter patients, an allogenic hematopoietic stem cell transplant is appropriate therapy if a return to chronic phase is achieved. Hydroxycarbamide can be an effective single agent, and low-dose cytarabine can also be used palliatively in older patients. ओके सो इब्राहिम बलोच मैसेज मी कि कौन सी बुक है. सो आई हैव मेंशन दिस इन द caption.